Ever purchased a genetic test or been thinking about doing a direct to consumer genetic test? Many people turn to buying their own genetic tests out of curiosity or necessity. But what happens when the results are confusing or alarming? I'm Kate Wilson, she, her, here with another episode of All Access DNA. In today's episode, we are talking to Andrew McCarty, he, they, about the ins and outs of genetic testing, including what to know about direct to consumer genetic testing. We also cover medical gaslighting, challenges in access to genetic services, and the rise of private practice in genetic counseling. Let's get started. Hi, Andy. I'm so excited to have you on the show today.
Yeah, it's great to be here. Appreciate it.
You work in private practice, which for those that aren't familiar, just basically means as a genetic counselor, you're not part of like a larger clinic or health system. So I was wondering if you could tell us a bit more about why you started a practice like this, as I think we're seeing more genetic counselors get into private practice.
Sure. Happy to answer that. So basically, when I got my start as a genetic counselor, I took a fairly traditional path of working at a large hospital system. In pediatrics, it's somewhat of a hybrid role. I was working a little bit in the lab, helping with utilization management, appropriate testing for the hospital. But separately, we had noticed that there was an issue with access in terms of like timelines to seeing the traditional kind of genetic counselor model that was there. And we worked essentially in building within the hospital a GC only practice. So we'd have non-geneticist clinicians referring to us to help facilitate genetic testing. And we found it to be really beneficial in terms of access, both in time and educating other clinicians. There was a lot of autonomy related to it. And frankly, by doing that, I found that I really enjoyed that type of professional setting. And I also saw the benefit with patients. So, even within the hospital system, there were still some limitations in terms of, access. So basically I wanted to take that and shift that to private practice model. Professionally, it allowed me a lot more flexibility, as well as, again, the big focus when I founded Clover Genetics was on access to care. So really the goal of Clover Genetics being that access to care is making sure we can focus on different payment models or otherwise to help patients that maybe the traditional health system doesn't work there. So it was a lot focused on kind of that access as well as professionally speaking, to allow that flexibility of, working on various different things, not just focusing on one area of genetics.
Right. So for those that may not be familiar, is not all genetic counseling positions are like this, but many are where, let's say, like I used to be prenatal. So I would see everybody that was on a prenatal case, but I didn't see too many other indications. And then I moved into oncology. So got to see patients that were either diagnosed with cancer or at risk for cancer. But it sounds like moving into private practice has allowed you more flexibility to see a variety of indications at different points potentially for people, so that there are folks that may not necessarily be able to get into one of these like health systems or hospitals for whatever reason, but they do have concerns and things that they want to talk to a genetic counselor about. And so then they can come to somebody in private practice like yourself who has a little bit more flexibility on not just the indications, but also where you can see them because you can do it virtually.
Yeah, exactly. So yeah, there's certainly, certain indications that major health systems may not be either willing or able based on the staffing concerns to handle things related to hypermobility, perhaps to like direct to consumer testing. These can be a little bit more. You basically need more niche practice, and same thing with licensure. It varies from state to state. There's more GCs in some states than others, so it can help kind of bridge that gap a little bit.
Well, and I'm glad you brought up the direct to consumer testing because I think a lot of folks are curious about their DNA. And we've definitely seen a rise in direct to consumer genetic testing. And there's folks that are getting results and then wanting to talk to a genetic counselor. And so sometimes that can be hard because there's a high volume potentially of those patients. And sometimes we're not always able to get them in the more traditional medical settings. Why do people usually want to do these direct to consumer genetic tests? Because we know they kind of vary widely in terms of reliability. And typically with direct to consumer testing, you have to repeat some of the testing at a medical diagnostic facility to confirm results. So why do people do direct to consumer testing?
Yeah, excellent question. So I would would say it's a couple things. One can just be plain curiosity. They're more accessible at times than going to a physician or other genetic counselor to get that testing. So ease of access. You can grab these from like CVS or other places at times. Though that's changed a little bit over time. So one can just be that ease of access and just curiosity of in terms of ancestry or, a health-based test. The alternative may be, cost. Sometimes these direct-to-consumer tests can be less in cost. With that comes potential lower quality. They may not have that, direct geneticist, GC, PhD reviewing that data in a broad strokes there. So that can impact that as well. But, a lot of times I think that access issue, again, it comes to that of they may not have accurate information of how much a clinical test costs. I've certainly heard from a lot of patients, oh, I thought this was going to cost like $2,000, $3,000, $4,000 when it turned out maybe they needed a panel that was only $250 or something. It can be cost, it can be struggles with the traditional medical system, not giving or providing them what they may need. A lot of different things there.
So a few different reasons why somebody might come to it. Some might be more, like you said, kind of just for fun. They're curious to learn a bit more. Others, it's because maybe they think something's going on, but they're not able to access it through traditional medicine or traditional means.
Correct. Yeah.
Um, One of the things that I was curious about is kind of those that maybe they're experiencing some sort of issue, and so they're doing these tests to get more information. The patients that you work with, like, what do they hope that they will learn from these tests? And then how really does reality end up matching those expectations?
Sure, sure. So, I would say lots of different folks have these tests, but the general consensus, or a lot of folks that we do see, often have these complex systems, what feels to be unrelated in terms of, certain chronic pain, or it can really be anything in terms of just various systems not functioning as typical. And they, the hope from this is that they get a clear diagnosis from this, or if not even that, at least somewhere to move forward from here of, okay, maybe these are some of the things that I look at. An area that often comes up is connective tissue conditions. We often see a lot of folks seeking these direct-to-consumer tests to at least get a direction to move forward. And in terms of reality matching expectations, not all, but certainly some of these direct-to-consumer products, their marketing is fairly assertive in what it will provide. And then when results are provided, doesn't always match up there. It oftentimes can be a lot of information, which can be helpful for some folks who want a ton of information, but it can also be very overwhelming. There can be genes on there that may be associated with fairly, scary diagnoses that don't in fact actually mean that they have a diagnosis. It just means there was a variant. We all have variants in our DNA, and it's determining, okay, which are benign, normal versus pathogenic, disease causing, and that's where a lot of these direct to consumer tests, they give that information but without that interpretation, which is often can be distressing or confusing at minimum. Yeah.
So, like, if somebody does get a result saying they have an increase for a condition, what does that actually mean in real life? Or how do you, as a genetic counselor, say, let me make sure this truly is what's going on? So, like, kind of what are the things to think about if somebody gets a result that says they're at increased risk for a condition?
Sure. Yeah. So first thing is to, kind of take a look at that variant. As a genetic counselor, my goal is to basically look at all the data related to that variant. Variants are typically classified along a spectrum from benign, likely benign, typically ones that we don't have a concern for, of uncertain significance, which falls kind of in that middle where we're uncertain. We may have conflicting data or insufficient data to be at least 90% confident. And when we get to likely pathogenic or pathogenic, that's where we are much more confident that there is something going on. And as a GC, my role is basically to look at that variant and see, okay, what data do we have on this variant? Has it been reported before? Is it common in the population? Are computer models saying consistently that it's going to change the protein's function, which could cause disease? There's a lot of these different elements there that we'd want to look at. And then, of course, lining it up and seeing, all right, what are the symptoms the patient is reporting? Do those line up? Or have they had this information verified through appropriate imaging or otherwise? So it's kind of taking all these clues, putting them together and determining, all right, is there a concern here? And with these direct consumer tests, the different regulation on it and in terms of like quality of the data can be less. So it's important to verify that on clinical based testing and kind of talking through that process of, okay, this is a good clue to start with, but we really should have this validated by a clinical grade test, CAP and CLIA being kind of two of the groups that would make sure that it's of an appropriate level there. But even then, there's varying degrees of quality.
Right, right. So these are all things that just I think they make interpreting genetic results more complicated because, right? I think, many as of us have worked with patients or even just talking to my family, they're just like, "Oh, well, it's positive or negative." And I'm like, there's a lot of gray space. And so one you mentioned like the variants, you also mentioned sort of the different certifications or kind of vetting the labs go through. Are there other things that add in to making it more complex to trying to interpret the results or like other examples you can share?
Yeah, yeah. So each good example of that is for certain genes, the mechanism that causes disease can vary. So you think of your genes typically like a sentence. If you change the spelling of the sentence, it can impact how that gene creates the protein that then impacts the function in our body. But sometimes they're more difficult to sequence regions like repeat disorders. So Huntington's is a good example of this, where there's basically a significant number of repeats that repeat over and over and over again. And if you get to a certain length, it then impacts the protein and causes those symptoms. So these direct-to-consumer labs and even clinical labs have to use different types of testing methodologies that have additional costs to them. So they're not always and consistently picked up by that typical sequencing technologies, understanding if there is even a clinical risk for that, and then B, doing that correct test is helpful. But even on some of these direct to consumer tests, if you get that raw data, it may show that there's a variant of one of these genes, but it may not actually be the fact that it does cause disease. And understanding those nuances there can be challenging at best.
Yeah. Yeah, yeah, exactly. So if somebody gets a concerning result from a direct to consumer test, what would you recommend their next step to be? What would you have them do next?
Good question there. So first thing is, not panic. I try and not overreact. I know a lot. I get test results myself, and still, I'm freaked out for a second, and then I, educate myself. But the first thing is to, probably try and reach out to a genetic counselor if you can get in contact with one, or another clinician who's knowledgeable in terms of genetic information. There's varying degrees of training that each type of clinician is provided. So there can be differences in that level of knowledge. But, I would say first is try and talk to a professional in terms of, what that information means. And ideally, if there is a concern based on talking to that clinician, a clinical grade test would really be kind of the next step there to validate, so to speak, that finding to see, all right, is that truly appearing, or is that lab error or some other concern there? Oftentimes, you may see this clinician and they'll look into the specific variant and look at the database and see, oh no, this has been reported benign or normal many times. We don't have a concern. So that's an option too. Testing may not be needed, or seeking that broader testing. And then once there's a true pathogenic potential result found, that's when discussing clinical management or having the clinician refer to that appropriate clinical management would make sense.
Right, right. Because if, let's say, for example, it was positive for something like a hereditary colon cancer gene, that clinician could then get the person plugged into the most appropriate clinic or follow up in terms to screen or monitor, do things to maybe reduce risk.
Exactly. Yeah. Yeah. It's yeah. Just in terms of the GC, yes, we're very much focused on the actual finding of the results, but then sending over to again have that screening because most genetic changes, not all, are not deterministic. Yes, they may increase your risk, but it's not true. You will definitely get this condition or that condition, especially in the oncology space.
Right. No, very important. And I think that feeds into kind of my next question, because you had mentioned a couple of things that might be misconceptions maybe that people have about direct to consumer testing or testing in general. One being that a result may mean that you absolutely have this. That's not always the case. I think one of the things that you had mentioned earlier too is maybe cost, that sometimes that they think if they go to a regular clinic and have clinical grade testing, it might be more expensive, but that's not always the case. Are there other misconceptions that when you talk to patients, that you see that they have about genetic testing?
Yeah. So the cost is certainly a big one. Even just that variability from location to location. There's different types of billing processes institutions can do. They can bill through insurance. Large systems may do institutional billing, where they're marking up the cost, billing insurance, and there can be benefits to patients for this, but it also can, based on your type of insurance, cause higher costs there. But outside of that, I think negative testing, even positive testing too, but more so negative testing. Negative testing doesn't mean that there isn't a familial or hereditary component. Genetic testing is something that we're still learning a ton about, and we haven't identified every single gene or every single variant within a gene. So the results you get are a little bit living in a way. Some of these labs even most should reanalyze over time. So just because it's a negative at one point does not mean that there's not a hereditary component. Yes, there's always an environmental component, but it's important to know, just because it's negative, it's not all clear. The big thing we focus on is like if we don't find anything basing on family history in terms of management. So, I think that's the other big thing there of like a negative. It's an informative negative versus an uninformative negative. And when we have family history and we know a change, we can get that informative negative. But otherwise, it can be lessened to have that negative.
And so what I'm hearing is that really genetics is more about sort of probabilities, adjusting these risks, and it's the genetic testing is not a definitive answer. So just because we find something or don't find something in your DNA doesn't mean you will or you won't get conditions.
Yes. Yeah, I would say that's a great way to put it there of, it's a lot of probability, population-based information of, we figure out what these, sequence of letters basically mean and do based on studying large populations and seeing, okay, with just this change, what does occur? And every individual is unique. And there's going to be variations based on ethnicity, based on environment, these other things that make it near impossible to have a true prediction. It's more of a probability, and this is not even further complicated with things like polygenic risks. So you have monogenic risks where there's a single change and a large shift in probability, but you can also have these small polygenic risk differences of maybe 1 to 2% increase or decrease risk that over in a whole of a lot of different polygenic risks can cause a difference in probability. But again, it's at the population level. So it's not specific to the individual. It's what you do with those probabilities and like how you manage that potential risk that is where you get the biggest impact, I'd say.
Okay, that's very helpful. And one of the things I think I find interesting about some of these direct to consumer companies is, and it's hard, I would say, probably in advertising, but they don't necessarily catch the probabilities or the nuances that you've been talking about, and sometimes they kind of market it as a definitive yes or no. So I think that's why sometimes I see people on the clinical side or medical professionals having these frustrations. But one of the things I've noticed on social media for folks that are posting about doing some of these tests is that some of them are people that have felt dismissed or ignored by the healthcare system. So there's sort of this push pull between, how helpful is this test? But I need this test to maybe confirm or help me get in the door of these medical clinics. Have you found a lot of folks that do testing because they do feel like they've been dismissed or ignored by traditional medicine?
Yeah, I would say for sure. I certainly hear, unfortunately, almost on a weekly basis of when I'm doing intake calls or otherwise, folks are sharing that, just thanking me for plainly listening and not telling them they're crazy or things like that. That to me is a sign that uh, health system broadly or specific individuals within the health system are either ignoring or uh, don't have systems in place to assist some of these patients that are very highly complex. So that leads to a scenario of, okay, if you have the advertising for certain companies, direct to consumer companies, they can very easily market of, this can provide some answers. And when you're marketing team is not directly talking to your lab science team or otherwise. There's different training, different goals in mind, essentially, too, that can oftentimes highlight those differences, highlight the things that are mostly true, but the nuance is lost for the bigger picture of the end goal of what is wanted there. So I think it certainly is prevalent, and oftentimes the science doesn't line up with what is shared, or it is, but it's lost to the noise of a lot of these reports.
Yeah, I was curious to know, and I don't know if there's been studies on this, like how often somebody is really having like medical gaslighting in essence, or being dismissed or not listened to versus they truly don't meet diagnostic criteria. Because I think that's one of the things too in the medical community is some of these conditions have like national guidelines, professional society guidelines, right? And we're trying to figure out, does somebody meet these guidelines or these criteria? How often do you think it is dismissive, gaslighting versus they truly don't maybe have this condition?
Yeah, that's a tough one, right? Because it's I don't know if there's any studies out there. Anecdotally, what I can say, is like I certainly have heard from patients about medical gaslighting. They've shared that we have a little spot on our intake of accommodations or otherwise to just make sure we're extra sensitive to that. And with the patient population we see, they're very self-selecting, and very rarely, I would say, do we have folks who truly aren't meeting like any of the diagnostic criteria for what they're coming in for. It's challenging, and cost of healthcare is you're not just going to go to seek healthcare. Certainly there are pathologies out there that does occur with, but I think the vast majority is folks are it may not be true medical gaslighting, though that does occur. I think the other piece is the systems built within hospitals to have folks be seen. One thing in particular, like hypermobile EDS, hypermobility. I know there are certain hospital systems for their genetic departments, they will just not see that indication because there is such a demand and such a lack of genetics professionals that it overwhelms a lot of these brick and mortar practices. So, it can also be the systems just like not being able to handle that as well. So it's I think a little bit of medical gaslighting, a little bit of systems, but I think for the most part, folks are just trying to get answers for the care that they feel like they need. Yeah.
Right. Yeah. It's there something doesn't feel quite right or something isn't off and they're looking for an answer to try to figure out how to feel better or move forward. Sometimes I think folks can feel stuck and so that's why they're looking for this additional information.
Yeah, yeah, and it's that feeling stuck of just just trying to find what meets their needs there, and or like certainly folks with comorbidities or otherwise, we work with a lot of people with autism spectrum disorder and just have like higher needs, and like a typical medical system or like a clinic, is challenging for other reasons too. So that can make it challenging too to even like communicate your needs to get those get yeah, the healthcare you need.
Right. Yeah. I think about folks that maybe have multiple conditions going on, and sometimes it can be challenging, right? Because you like, I'm going to the cardiologist, but I also, let's say I'm having, I don't know, breast cancer. And it's sort of like, well, the cardiologist is like, well, I'll treat your heart issue, but the cancer stuff, you got to go see somebody else. But then there's this space where, I mean, your body's organs talk to each other, your systems talk to each other. And so sometimes you need that care where you're kind of at that intersection of all these sort of threads health wise.
Yeah, yeah, and that's a big thing too of like it seems like everyone gets the care for those specific systems, but when they cross and there's like multiple things, big picture is really challenging. I think genetics, geneticists, genetic counselors kind of look at that big picture or in like a good space for that. But outside of that space, it's certainly not the majority of clinicians that are taking the time or even have the time, not even to take the time within the systems that they work.
That's a good point. I mean, I think we've talked about it, but what are some of the benefits you would say of using a direct to consumer company? Because I think some folks may be more pessimistic and say there aren't any benefits, but it sounds to me like there are times where it could be helpful to somebody.
Yeah, yeah, I would say it can certainly like motivation is one of okay, if you've identified something, that can then bring you to medical attention to identify something. Yes, certainly direct to consumer companies and testing can identify true pathogenic findings. Again, it's a noise within there. So the big thing is bringing someone to medical attention or starting that conversation. Even with like ancestry testing, that can start a conversation with your family members of like, well, hey, there's this family history as well. You should get that looked at or otherwise, and it can make those broad connections of folks maybe who don't know their family. So I think there are a lot of benefits in terms of the communication, the connection, and it's not all bad. Direct to consumer does offer testing that can identify variants. It's just then we need to validate those further. It's the big takeaway there. So I think there's a benefit, but of course there's a cost. So if cost is limited, maybe clinical based testing would be the better use of those dollars. But it's
And I would say, what are some of the risks of this type of testing? I think we've talked a little bit about, accuracy or kind of what's being looked at, what type of methodology is being used. But what are some of the other things people should consider before they have direct to consumer testing?
Yeah. So one big thing, and it definitely has been in the news, is data security of who actually owns that data. Yes, it is your sequence, but you're signing essentially a contract, and what is done with that data, is that able to be sold to other folks? Do you control that data or that information? So that's a big potential risk there, and understanding of that. And I always encourage like reading of consents of and they can vary based on the types of testing. Academic labs tend to be a little bit more reserved, and asking for permission for research or otherwise. So that's number one. Number two is kind of incidental findings. So typically in my counseling, even if the likelihood is very low, yeah, very low is a good way to put that. It is it is possible to identify things like non-paternity or things like consanguinity, where two individuals related by blood have a child together. Interesting anecdote from my personal life. I knew a friend who did ancestry testing. They were very, very proud of their Italian heritage, and turned out that they, on receiving this result, had no Italian heritage by the report. Again, there's other logistics involved there, but that can potentially impact someone's identity, and that has challenges in and of itself. So those are big ones. Misleading results, of course, too. So those, like, if it's truly negative, great, but just because a test is negative doesn't mean it tested everything. There's very small targeted panels that maybe test for like the Ashkenazi Jewish population, maybe three of the highest risk BRCA variants for breast cancer, but not the whole gene, which may actually be beneficial. So, being aware of that. And same thing on a positive. You might receive what seems like a positive and then get management based off of that, whereas it may have been not a true positive, and that the management can potentially increase harm as well. So it's important to make sure the testing is up to par there.
Right. Yeah, I always think about a patient I had, this was many years ago, but when direct to consumer testing first came out and their physician had misinterpreted a result and was kind of recommending basically surgery, like a prophylactic surgery to help reduce cancer risk. But the patient themselves, we ended up doing the clinical testing and they were not positive for what they thought was going on. And so I think that's an important take home too, is that sometimes the recommendations can be involved. So that's another reason to then say, okay, you may, to consider confirming this with clinical testing and find somebody like yourself that is a trained clinician that can help interpret these results.
Yeah, I agree. It's both ends of the spectrum. It's important to make sure the results are what they say they are, if you're going to do a major surgery or intervention.
And if we have a listener, that's had a direct to consumer test, so they've already taken it. uh, and let's say, you talked about if something comes back that they're concerned about, how they should try to find like a clinician or jet counselor. Let's say they got it back and they don't really see anything that's concerning. Is there any follow-up that they need to be doing?
That's a good question there. So I would say if there's nothing concerning on the report, it's really for their health care. It's always good to check in with their clinicians in terms of, okay, do they have any strong family history? Do they have any specific health history that's of concern? I think the best thing with specific to the direct-to-consumer test is that if it came back negative, just be aware that it's not, a panacea, so to speak, of, okay, that was negative. I don't have any concerns. There still should be like, population level screening, checking in. There's some red flag materials out there of, okay, what are the main things to look for in terms of a genetic concern, which can be helpful, seeking out care from their PCP. But yeah, I think if they're interested in being preventative about their health or have that health history, I think seeking care or at least doing research on clinical grade genetic testing or talking to a genetic counselor, geneticist is probably the best next step, just to make sure that nothing's missed there, just because there's so many limitations when it's a direct to consumer test that many things can and are missed on that. It's just that would be my concern, that something would be missed where there could be prevention available.
That's a good point. And then I would say to close out, what is something that you want our audience to take away from this conversation today in terms of thinking about maybe access to genetic testing or direct to consumer genetic testing? What is something hope that, if they only can remember one thing, what is it that you hope they remember?
Yeah, I would say that, genetic testing has become a lot more accessible. So not all these tests are thousands of dollars. They're good clinical grade tests that are available for potentially similar costs to direct to consumer testing if the research is done and you take a look at that. So just understanding there are differences. Not all tests are equal and the results vary. So it's important to just, really do your research, ask those right questions, and depend on appropriate board certified clinicians who can provide that information.
Well, Andy, I thank you so much for talking us through your private practice, but also talking about the direct to consumer testing and also things that folks should be thinking about. I just appreciate hearing your input and appreciate your time with us today.
Yeah, of course. It was a pleasure chatting with you today. And yeah, it's been great.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.